implemented. So I'm especially enthusiastic about the topic for today. We'll turn it back over to you and look forward to learning. Thanks.
Thanks, Dr. Seiberry. So just as a few reminders, we are recording this webinar. All of the information that we share is intended to be for educational purposes only and not to replace clinical decision-making. The webinar is being simultaneously transmitted in English, Spanish, and French, which you can select using the menu at the bottom or top of your screen. Finally, please submit questions using the Q&A feature at the bottom. And at the end of each of the webinar, we will have a time where we'll go through the questions with all of our panelists. Just as a reminder, here are some of the sites where you can find content and educational material that might be mentioned in the talks today, but also that have been created as part of this project and with relevance to infection prevention control. In particular, on the Open Critical Care portal, there is a compilation of infection prevention control and PPE training materials, as well as visual aids. Those can be found on the suggested trainings page, which is linked off of the home page. There's also a course on personal protective equipment that was created by collaborators around the world and led by Lifebox with support of USAID, STAR, and UCSF. So the links can be found here. So today it's my great pleasure to introduce our three panelists and speakers. First is Dr. Debbie Yakoa. Dr. Yakoa is a professor of medicine, a member of the infectious disease division at the University of California, San Francisco. She's medical director for hospital epidemiology and infection prevention at UCSF Health. She has also served as the co-chair of the Healthcare Infection Control Practices Advisory Committee, a federal advisory committee that provides input to the U.S. Centers for Disease Control and Prevention on issues related to IPC. She's currently serving as the vice president for the Society of Healthcare Epidemiology of America and will become the president of this organization in 2023. Next is Dr. Rogers Ayabari. Dr. Ayabari is a sepsis clinician, infection preventionist, and current program coordinator for medical countermeasures at the Global Health Security Department of the Infectious Disease Institute in Kampala, Uganda. Dr. Ayabari has multiple years of experience in advanced IPC, as well as in-service healthcare worker training and capacity development for clinical research during outbreaks. He's served as a member of the National Task Force for the Ministry of Health in Uganda in support of infection control and infectious disease management for emerging and re-emerging pathogens, including Ebola and COVID-19 efforts since 2018. And finally, Dr. Shevin Jacob. Dr. Jacob is an infectious disease physician and currently senior clinical lecturer in sepsis research at Liverpool School of Tropical Medicine. Over the last 15 years, he's been conducting research aimed at improving management and outcomes of patients with who are hospitalized with life-threatening infections, with a particular focus on sepsis in Uganda, where he currently lives. He's he directs the African Research Collaboration on sepsis and has also served as a consultant for the WHO for improving clinical management of sepsis and viral hemorrhagic fevers in resource-constrained settings. He is team lead for the Global Health Security Department at the Infectious Disease Institute in Uganda, and during the COVID-19 outbreak, has served as a member of the Uganda Ministry of Health Case Management Pillar for COVID-19. Thank you all so much for joining, and without further delay, we're going to hand over to Dr. Yakoa for the first presentation.
Great. Thanks so much, Mike. And thanks so much for inviting me to discuss this topic today. It's a real pleasure to be here and to be able to participate. So these are some of my key messages for this talk. I'm not going to read over all of these now, but I will come back to these at the end. I do want to point out that I had the pleasure of being able to look at Dr. Ayabari's slides ahead of time, and it's really striking how similar the challenges are in our settings. So during the next half an hour or so, these are the topics that I'm going to very briefly touch on. So I'm going to talk a little bit about the general framework that we use for infection prevention and control to safely provide healthcare during this era of COVID-19. But I'll also highlight some of the huge challenges that have been posed by COVID-19 in applying this framework. And then I'll touch briefly on some issues around respiratory protection, controversies around the use of medical masks versus respirators and when to wear which, and then what constitutes an aerosol generating procedure. And then I'll end with just a little bit about what we can potentially learn from hospital outbreaks of COVID-19. So I'll start by saying that applying infection prevention and control during this COVID-19 pandemic has been incredibly challenging. This is a virus that we've only known about for the past 16 months. And so we are continuing to learn more and more about the way this virus is transmitted on nearly a daily basis. And then on top of all of that, the virus continues to evolve in ways that impact the epidemiology of transmission. So we are really trying to build this plane as we fly it. And that's required us to be really nimble about being able to make adjustments in our practices and our recommendations as we learn more throughout the course of this pandemic. So I think many of you have seen this diagram before. This is the hierarchy of controls that's used by the US Centers for Disease Control and Prevention in minimizing risks in the workplace setting. And this is the framework that we also use for infection prevention and control. And you can see it's a inverted pyramid where the most effective strategies are at the top. And then as you go down, you go to lesser and lesser effective strategies. So at the very top are strategies that are aimed at eliminating the hazards completely. And of course, these are the most effective strategies. Then you go down to substituting out hazards that are less of a risk, down to engineering controls that change the physical environment in a way that minimizes risks, and then down to administrative controls that change the way that people work and behave to minimize risk. And then finally, at the very end, you see the use of personal protective equipment, PPE. And PPE is at the bottom of this pyramid because PPE requires that you are aware of the hazards, that you have access to the PPE that you need, that you're using the PPE in the appropriate way. So lots of contingencies that affect the effectiveness of PPE. And here I've included some examples of strategies that are specific to COVID-19 that fall into these different layers of controls. So at the beginning of this pandemic, I think many of us were trying to eliminate the hazard as much as possible by minimizing the number of people who are in our healthcare facilities with COVID-19 who could potentially transmit infection to others. So that meant closing down non-essential services, canceling non-urgent surgeries and visits, not allowing visitors to enter, restricting non-essential staff, etc. But what we've learned is that these elimination strategies are not very sustainable over time because we still need to be able to provide essential non-COVID-19 care to our patients. And so during the course of this pandemic, we've come to rely more and more on those lower layers of controls. For example, engineering controls, and people have been very creative about figuring out ways to encourage physical distancing with physical partitions or rearranging seating arrangements and clinic waiting areas, et cetera. And we've tried to optimize ventilation as much as possible in our healthcare facilities. And then lots of examples of administrative controls, emphasizing the importance of basic practices like hand hygiene, screening everybody coming into the healthcare facility for symptoms, discouraging people who are sick from coming to work, things like staggering the timing of breaks so that staff aren't sitting in a small room with their masks off, eating and drinking in close proximity at the same time. So lots of examples of administrative controls. And then finally, the use of personal protective equipment, PPE, and I'll talk more about that in just a couple of minutes. This is the way we approach preventing the spread of infections in healthcare facilities. This is a US CDC's isolation precaution approach. It's a two-tiered system. So standard precautions that are applied to all patient encounters. So all patients across the board, regardless of their underlying conditions, and then some additional transmission-based precautions that are used for infections that may need more than just standard precautions to prevent spread. And the concept of standard precautions is even more important during this time of COVID-19 because standard precautions assumes that all patients are potentially infectious, which is definitely true for COVID-19, and that these basic practices need to be adhered to for all patient encounters. So practices including hand hygiene before and after all patient contacts, the use of personal protective equipment as appropriate to that patient and the kind of activity that you're going to be performing. And then I mentioned some transmission-based precautions. And these are the three categories that we have traditionally thought about. Contact precautions that are used for infections that are spread mainly through direct contact with the patient or the patient's contaminated environment. And then two categories of infections that are spread through the respiratory route. Droplet precautions for infections that are mainly spread through large respiratory droplets that don't travel very far, like influenza or pertussis. And we require staff to wear a medical or surgical mask when caring for these patients. And the other bucket is infections that are spread through the airborne route. So small droplet nuclei that can remain suspended in the air for long periods of time, can travel along air currents, like measles or chickenpox or pulmonary TB. And for these patients, we require staff to wear a higher level of respiratory protection. So an N95 respirator or equivalent or higher level of respiratory protection. And we try to put these patients into rooms with special ventilation. And one major challenge posed by COVID-19 is that it has pointed out that maybe it's not such a clear-cut distinction between droplet and airborne, that it may be more of a spectrum of transmission rather than a clear-cut dichotomy. And I'll come back to this concept again when I talk about respiratory protection. Another basic strategy that we've used is screening patients for symptoms that may be indicative of infections that are easily spread as soon as possible after they enter our healthcare facilities. So screening for fever, for cough, for fever and rash, etc., in order to be able to quickly isolate those patients and care for them safely. And we've tried to do this for COVID-19 as well. But again, another major challenge of COVID-19 is the fact that we now know that patients can be pre-symptomatic or in some cases completely asymptomatic and be infectious. And in fact, we know now that patients are probably most infectious right before or right around the time they begin to develop symptoms. And when that became apparent, it was really a game changer for infection prevention and control because it meant that we couldn't completely rely on symptomatic screening and triage to be able to identify and isolate patients who are infectious. And so that has led us to have to apply prevention strategies very broadly. So not just to patients who we suspect of having COVID-19, but to all patient encounters. And those include non-pharmaceutical interventions like physical distancing, the use of face masks, the use of eye protection. These are just some examples from UCSF of visual cues that we put into place everywhere, just as reminders to patients and to visitors and to staff to physically distance as much as possible. I mentioned the use of face masks. Universal masking has been adopted by most healthcare facilities. And this serves a dual purpose. It's source control so that the person who is infected and wearing the mask is going to be less likely to transmit infection to others. And as protection for the person who is wearing the mask, protection from becoming infected. We've also really tried to encourage our patients and visitors to mask as well. And this includes patients who are in exam rooms, who are in hospital beds, unless there are medical contraindications. Many of our healthcare facilities have also added on, in addition to universal masking, the use of eye protection for all patient encounters as an extra layer of protection. And then just to mention that there have been lots of challenges in access to diagnostic testing during this pandemic, but many of our healthcare facilities, at least in the US, have adopted pretty aggressive diagnostic testing strategies. So not only testing patients with symptoms that are suggestive of COVID-19, but also testing of some asymptomatic individuals in high-risk situations where the risk of transmitting to others is relatively high. For example, for patients who are about to undergo an aerosol generating procedure, or for patients who are being admitted to the hospital. And just to quickly mention some of the impacts of variants and vaccines on infection prevention and control. This is a list of variants that are currently on the CDC's list of variants of concern. And you can see that all of these variants are associated with increased risk of transmissibility. So they appear to be more easily transmissible from patient to patient, from person to person. And that, of course, means that there's increased potential for healthcare associated spread. And so we have even a smaller margin of error in areas where these variants are circulating for any kind of breaches or lapses in infection prevention practices, which can then lead to transmission and COVID-19 outbreaks in our healthcare facilities. But on the upside is the very positive impact of vaccines. And I know that access to vaccines is still very limited and variable in different areas of the world. But when vaccines are available, it is important to strongly promote vaccination. There's a lot of accumulating data that vaccination is very protective for our healthcare personnel. This is just one example of a study led by the CDC, where they looked at about 4,000 healthcare personnel, first responders, and essential workers. And they tested these participants on a weekly basis using PCR testing for SARS-CoV-2. And they concluded that those participants were fully vaccinated were 90% less likely to get infected. So very, very effective at protecting our healthcare personnel. And that's led to some relaxation around recommendations. Our US CDC no longer recommends, for example, that vaccinated healthcare personnel need to quarantine after exposure. So that means that they can continue to work, but they just need to self-monitor during that incubation period. And this has been hugely beneficial in alleviating some of the staffing shortages that our healthcare facilities have been experiencing. And there's no longer a recommendation to quarantine after travel. And we're hoping that as more and more people become vaccinated, that we'll be able to slowly increase the number and the density of staff and patients within our healthcare facilities so that we can move back towards providing full service in terms of healthcare and also teaching and learning. And just to mention quickly that most patients with COVID-19 don't need to be hospitalized. They're not sick enough to need to be hospitalized. And to point out that the CDC website does include some very useful practical guidance around how to care for someone who is sick at home. And most of the recommendations are very common sense, straightforward, including things like trying to separate the sick person as much as possible, ideally in a separate room, but understanding that there are many circumstances where that is not possible, at least trying to physically distance as much as possible, optimizing the ventilation in the home by keeping windows open, avoiding visitors. So again, very, very common sense recommendations. The sick person and caregivers should be wearing a mask when in close proximity if possible, and cleaning hands often, cleaning surfaces regularly. And just quickly to touch on some issues around respiratory protection. As I mentioned, two major categories that we usually think about. Infection spread through larger droplets, where we use droplet precautions. Infection spread through these smaller droplets and particles, where we use airborne precautions. And the epidemiology of SARS-CoV-2 suggests that transmission is mainly through short-range, large respiratory droplet transmission. We don't see the really widespread, extensive outbreaks of infection in hospital settings that we do with infections like measles that are primarily airborne transmitted that, with COVID-19. However, it does appear that airborne transmission can occur under special circumstances, in particular in enclosed spaces with poor ventilation where there's prolonged exposure, leading to some of these super spreader events that we've all heard about involving choir practice or restaurants or gyms. And what's become apparent is that transmission risk is dependent on a number of factors. The infectiousness of the source patient. As I mentioned, patients appear to be the most infectious right before or right around the time they become symptomatic. So if the exposure occurs at that point in time, then the risk of transmission is going to be relatively high. The forcefulness of respiratory emissions, so aerosol generating procedures associated with higher risk of infection, the volume of shared airspace, how long you're in that shared airspace, the density of infected people in a space, and then whether the infected person or the exposed person is, whether they are wearing personal protective equipment. All of these factors interact and determine transmission risk. So what does that mean in terms of respiratory protection? Should we be wearing masks or respirators? And the bottom line is that there is very limited evidence to really adequately compare the effectiveness of medical or surgical masks versus respirators when caring for patients with COVID-19. There have been several published systematic reviews and meta-analyses that have generally concluded that low quality evidence does not clearly favor respirators over medical masks in a non-aerosol generating procedure situation. But the bottom line is that the data is very limited. And because of the complexity around transmission dynamics, because of this paucity of evidence, what respiratory protection should be worn in a non-aerosol generating procedure situation continues to be controversial and variable across guidelines. And of course, is very much impacted by the shortages that we've all experienced in terms of N95 respirator supplies. On this slide, I've just summarized some of the PPE recommendations for these 4 guidelines. There's good consensus for an aerosol generating procedure situation where the recommendation is to wear a respirator plus eye protection plus gowns and gloves. But you can see that there is variability for non-aerosol generating procedure situations. So the World Health Organization guidelines and the UK National Health Services guidelines currently recommend the use of medical or surgical masks plus eye protection plus gowns and gloves in a non-AGP setting, as opposed to the US CDC and the European CDC guidelines that currently recommend the use of a respirator plus eye protection and gowns and gloves. And again, this variability reflects the lack of high quality evidence, the very complex transmission dynamics that we are just beginning to learn about, and then of course, very much impacted by practical issues around shortages of N95 respirators. And we've all experienced shortages in all kinds of PPE during this pandemic. And that has spawned a huge black market around sale of PPE, including N95 respirators. So I just wanted to point out this very practical, useful website where they go over some of the things that you can look out for as signs that a respirator may be a counterfeit or a fake respirator, and some of the things to look out for on websites selling these respirators that may be clues that the respirators that they are selling are counterfeit respirators. So I urge you to take a look at this really useful website. And then just very quickly, what's an aerosol generating procedure versus not an AGP? Hugely controversial, no consensus even prior to COVID-19, as you can see by the differences in these various guidelines. This is data from the SARS epidemic, highlighting some of the procedures that were associated with higher risk of transmission to healthcare personnel from patients with SARS to healthcare personnel associated with these procedures. And that includes procedures like endotracheal intubation, tracheotomy, non-invasive positive pressure ventilation. And this data has been extrapolated to SARS-CoV-2 to COVID-19. This is from the CDC website and clearly points out that there is no expert consensus and there's not sufficient supporting data to create a definitive and comprehensive list of AGPs for healthcare settings. And they list some of the procedures that I've just described and some other procedures that may or may not be associated with aerosol generation. But this lack of guidance and scientific data has led to many professional societies coming up with their own list of their own procedures that they consider to be aerosol generating. And this has led to a huge amount of variability and confusion, variability between healthcare facilities and what they consider to be AGPs. I just want to point out this really thoughtful article from Mike Klompus in the group at Brigham and Women's Hospital in Boston, where they talk about the concept that maybe we're not thinking about this in the right way. Maybe we shouldn't be thinking about so much about aerosol generating procedures, but rather as situations where the risk of aerosol transmission is relatively higher, depending on factors like the patient having forced air moving over their respiratory mucosa, for example, during CPR or non-invasive positive pressure ventilation or while receiving nebulized medications. The infectiousness of the source patient, how close you are to the infectious source. So if you're intubating a patient, you're right in that patient's face near their oral pharynx, that may be the risk factor that determines increased risk of transmission. And then how long you are in contact with the infectious source. So similar to the risk factors that I described before. And then finally, just a few things to point out from what we've learned from COVID-19 hospital outbreaks. So these are some common themes from our experience, from the experience of our colleagues, from the published literature. And they include observations like healthcare personnel exposures often occur in the community setting, from household exposures, from other community exposures. Healthcare personnel exposures, even those that occur in the workplace, may not be associated with activities that are part of providing care to patients. So many examples of exposures and transmission events involving healthcare personnel who are in close proximity, taking breaks, eating, sharing meals with their masks off, again, in close proximity. Many of the large outbreaks that have been described have been linked to patients who were infectious prior to their COVID-19 diagnosis. I think pointing out the fact that once these patients are diagnosed and they are appropriately isolated and everyone is wearing appropriate PPE, that the risk of transmission is substantially minimized. And then risks involving inconsistent patient masking and inconsistent healthcare personnel use of appropriate PPE. This is just one example of a really nice description of a large outbreak, also from Brigham and Women's Hospital in Boston. This involved 14 patients, 38 staff. The relatedness of their infections was verified through whole genome sequencing. And the index case was a patient with chronic lung disease who had baseline respiratory symptoms, admitted for an elective procedure, who was PCR negative on admission. During the course of hospitalization, developed worsening respiratory symptoms, was treated with nebulized medications and high flow oxygen, so received some potentially aerosol generating procedures, was finally retested on hospital day number 11 and found to be PCR positive for COVID-19. By that time had infected many of his roommates, who then went on to infect their subsequent roommates. The patients infected a number of healthcare personnel infected their colleagues, leading to this very large outbreak. And some of the risk factors that they identified for healthcare personnel infection included being present while an infected patient was receiving nebulized medications, caring for patients with respiratory symptoms, interacting with other staff who were subsequently found to be PCR positive, spending relatively longer periods of time exposed to infected patients and not wearing eye protection. So based on their observations, these are some of the responses that they proposed. To consider, if you have access to diagnostic testing, doing repeat testing for some patients. So in addition to testing patients on admission, repeating their test on hospital day number 3 to 4, because some patients may be already infected at the time of admission, but too early in their infection to be detected at that point in time, and then go on to have higher levels of viremia and become infectious later on during the hospitalization. To consider serial repeat testing of patients who are undergoing frequent AGPs, to consider serial testing of patients in shared rooms, to be alert to the risks associated with AGPs, and to consider having staff wear N95 level respiratory protection during AGPs, even for patients who aren't suspected of having COVID-19, and then performing AGPs in private rooms with the doors closed. So I'm going to stop here, but just want to summarize by showing this graphic from the New York Times. This shows the number of new COVID cases per day globally. And unfortunately, you can see that the trend is still very much on the steep upward side. So we are far from out of the woods in terms of the COVID-19 pandemic. So that means that we have to continue to focus efforts on protecting healthcare personnel and patients from healthcare-associated COVID-19 infections by adhering to prevention practices, to be aware of pandemic fatigue. Everyone is exhausted by this point, but really important to encourage them not to let up on adherence to infection prevention practices. Promote vaccination if you have access to vaccines. Continue to evaluate new science, best practices, learn from our own experience and experience of others, and be prepared to continue to be nimble in making adjustments in response to new knowledge, to future surges, the rise of variants, and whatever else comes down the line. And to be aware that COVID-19 will likely require long-term adjustments to practices and behaviors. So I'm going to stop here and happy to take questions at the end.
Dr. Yakoa, thank you so much for that talk. As Dr. Ayabari is starting to share his screen, I'll just remind everyone, please use the Q&A to submit any questions, and we will get to those in about 15 minutes or so. Dr. Ayabari, over to you.
Thank you so much, Mike, and thank you so much, Deborah, for that really elaborate introduction. I think this will make my work easier moving forward from here. So today I'm going to be sharing about Uganda's journey with IPC during this pandemic, and some of the things I'll be sharing on include, lessons learned from IPC implementation in a resource-limited setting, and then we'll be discussing how IPC strategies for COVID-19 were implemented in Uganda, and then how practice has evolved in light of the new information. So the emergence of the SARS coronavirus 2 in late 2019 found Uganda when they had been in a 1.5-year battle preparing and responding to EVD. And to Uganda's credit, the 4 spillover cases from the North Kivu outbreak into Western Uganda didn't translate into community transmission. And this gave indication for a 92% preparedness score using the WHO assessment tool 6 months earlier. However, despite these good scores, further assessments through national simulation exercises did highlight gaps in IPC practice, hence highlighting IPC as a key area for intervention moving forward. Then 2020 happened, and the new coronavirus was reported in China, and Uganda had the first case from a traveler returning from the Middle East on March 17th, 2020. And these numbers have since increased over 40,000 cases, including now close to 400 deaths and over 1,000 healthcare worker infections. And also important to note is that at this time, the Ministry of Health was dealing with other health emergencies, including yellow fever, cholera, Rift Valley fever, and Congo-Crimean hemorrhagic fever. So testing the response to COVID-19, the structures that had been set up for EVD response were quickly co-opted to support this new threat at the horizon, and part of the mandate included drafting IPC guidance for healthcare workers and training them on this new guidance, especially in facilities which were likely to receive returning travelers within the country, and then also how to best integrate best IPC practice into routine activities like triage, providing clinical care, and community-based activities. So the Ministry of Health adopted the WHO strategy for IPC that was published in January of 2020, whereby we focused on early recognition, strengthening compliance to standard precautions, and then implementing contact, droplet, and airborne precautions depending on the level of care being given, and then also administrative and environmental controls. So how did this happen? So for environmental and engineering controls, especially in the context of COVID, airflow management is one of the key elements to consider. And this was one of the toughest areas to address since majority of the existing hospital structures are not well engineered to allow for optimal airflow to prevent contamination. And also as of December last year and early this year, there were no pressure regulated rooms countrywide. So putting people in negative pressure rooms, in negative pressure isolation rooms was not possible. And then also the emerging need for space meant that we needed to create additional space where to isolate people. And the Ministry of Health recommended that mental health units be temporarily converted into COVID-19 treatment centers to deliver care for moderately and severely ill patients. So the only option that was viable in this setting was to rely on natural ventilation and spatial separation to minimize many people being congregated indoors. And this had implications for bed capacity on the ward, because we had to reduce the number of beds on the ward in order not to have more people congregating, but also underscored the importance of enhanced screening so that we minimize the risk of mixing COVID-19 patients with those who don't have COVID. For administrative controls, we took the approach of looking at how staffing operations would change, but also how patient welfare or patients' activities within the hospital would change. And although the ministry offered guidance, it was up to the discretion of the leadership of these facilities to see how well to adopt some of these guiding principles. So some of these included repurposing of staff from other departments to support patient care, using fewer staff members to minimize PPE consumption for every shift. And then earlier in the pandemic, some hospitals piloted having staff become residential in the hospital, meaning you do your 2 weeks shift while you're a resident and you're tested before going home. But due to resource constraints, this later changed to being able to provide transportation for health workers to go home, especially during the lockdown when public transport was shut down. The Ministry of Health also approved risk allowances for dedicated staff working on COVID treatment units, which also fed into the fact that we had to have fewer staff to be able to sustain that intervention. For patient welfare, the biggest challenge we had was that culturally in Uganda, patients normally come with a relative or next of kin whom we refer to as an attendant or a caretaker. And their role is to make sure they attend to all the other additional needs, including food, personal effects, communication, or buying medicines that may not be available in the formulary of the hospital. But since we wanted to minimize risk, these people could not come into the isolation facilities. So the hospital had to mobilize means for making sure that food, personal effects, and communication are catered for all patients that are under their care. Also, in addition, because most patients were early in the pandemic were picked up from borders, meaning they were traders or bus drivers or returning truck drivers, what happened was that some of these people would come with some belongings with them into the isolation unit. And also we had to come up with novel ways to manage and secure some of their property for the duration of their isolation. So on the right, for screening and early identification, we have a local adoption of screening algorithms earlier in the pandemic, and these were based off information coming from China. And the aim was to make a simple algorithm that could be implemented by a non-clinician. And one of the key elements of considered was history of travel as well as symptomatology. But as community transmission became well established, the criteria for travel was discarded. And we only focused on expanding the symptomatology and expediting the return of lab results. In mid to late 2020, we started noticing hospital-based clusters regardless of the screening efforts at the healthcare facilities. And in order to mitigate some of these inpatient clusters, we adopted an enhanced inpatient surveillance strategy, so that even though you're admitted, someone comes and reviews you on a daily basis to see if you have new onset worsening symptoms that could be associated with COVID-19. There are also establishment of healthcare worker protection teams, which were constituted by local clinicians and IPC focal persons. And these worked with a coordinating team from the Ministry of Health to track, report, and investigate healthcare worker infections at their facilities. Guidance on PPE use was really a complex dance involving rational and evidence-based recommendations versus healthcare worker fears regarding a new pathogen. And I think the one element that makes Uganda unique is that we had a lot of heavy influence, especially on a negative sense, from the fact that from close to 2 years of preparing for EVD, there was a lot of familiarity with that kind of PPE, and then also media reports that we saw in the TV and print before COVID came here. All healthcare workers in Asia and in Europe were donning coveralls. So this posed a barrier, for implementing best practice. In addition, due to the EVD preparedness efforts, the country had a large stockpile of coveralls in high-risk regions, which were easily accessible. So healthcare workers immediately started using coveralls from the word go, while we waited for gowns to be put through the international procurement, which also suffered significant constraints. Then also, to add another spanner in the mix, there was this ongoing global debate regarding droplet versus airborne transmission of COVID-19, which affected respirator use. So at the end of the day, we agreed on this approach, as you see in this slide right here. And the agreed approach was that we would put PPE recommendations in 4 layers or 4 levels. Level 1 is basically for when there is no patient interaction, meaning if you're a healthcare worker or any adult in society, make sure you have a cloth mask and closed shoes. Level 2 was for when there is patient interaction but no contact. So for example, when you're screening. And then level 3 and 4 were for when there was patient contact, with the caveat that for level 3, you don't have any aerosol generating procedures. And for level 4, you have aerosol generating procedures. Some of the caveats were that for level 3 and 4, coveralls and gowns could be used interchangeably depending on what's available. However, we had to reach a compromise where most healthcare workers felt double gloving made them safer. So we recommended use of double gloves versus a single glove as recommended by WHO and CDC. And then also the use of gumboots was still the preferred footwear inside COVID treatment centers. But shoes could be used for any other area, including other routine wards and screening centers and ambulance services. In order to make sure that the healthcare workers are equipped with, what they need to implement best practice, we undertook a national PPE quantifying exercise. And because this happened at a time when we hadn't had so many patients, it was hugely based on assumption. And then also the other thing is that even after the technical team had made these assumptions, handing over to the people who have the money, there was loss of communication, and therefore in the long run, some of these other PPE elements, including coveralls, ended up featuring in the first major procurement that was made by the government of Uganda. But at least one of the key elements that was delivered from those deliberations was the fact that we were able to have a case to adopt gowns rather than coveralls. And here we were just looking at PPE requirements for 2 of the major referral hospitals that were taking many of the patients that were returnees over a 2-week period, plus the ambulance service that actually moves these patients. And every 2 weeks, they required over 5,000 coveralls. And when we looked at the cost of using coveralls, disposable gowns versus reusable cotton gowns that could be laundered, we saw that we could be able to save over $1 million within a space of 3 months. And this gave us a justification for phasing out coveralls and the adoption of cotton gowns in some hospitals, and additional feedback from healthcare workers that were using these gowns, gave us stronger evidence to move in that direction. The other sticky element was regarding respirators. So routinely, at least in my practice, fit testing is not done for all healthcare workers, but we do recommend that a seal check is done as part of the standard donning procedure for a respirator. And because we don't normally do fit testing, we have the challenge that you always have one size of respirator supplied at a time. So due to the global supply chain constraints with N95s, the MOH recommended use of KN95s, which came as donations from partners, but also from government of Uganda procurements. And these were cheaper, although they did not fit as well as the N95s from the reports we got from the end users. The government was able to work with Africa CDC to secure the proper N95 masks, but these were only available to government facilities or public facilities. So meaning the other hospitals where services are for paying, the lack of these masks meant that the cost of care went significantly up, or the exposures there were higher. since they didn't have the ideal PPE. So we didn't have any national guidance to support large-scale decontamination of respirators in Uganda. And I think also this is due to the fact that although we did have a surge of cases in late 2020, we didn't have such a huge stock out of respirators to consider the contamination as an option, because the KN95s were available in adequate quantities. But in order to patch up gaps from local stockouts in certain hospitals, local IPC committees adopted measures of extending the use of the respirators, so that each healthcare worker could use a respirator for anywhere between 3 and 7 days and have it kept in a rigid plastic container so that it is safe when it's not in use. But that was never adopted nationally, and different hospitals used alternate measures to extend the use of the respirators. Also, to include monitoring so that orders are placed quite early, the clinical case management pillar developed a tool to assess treatment center readiness for patient management. And this helped administrators monitor availability of PPE and other IPC enablers, as you can see in this spider plot here, so that by just looking at this, then the managers are able to know which elements they need to prioritize in the next 2 weeks. The hospitals which adopted cotton gowns, these were designed locally with input from the clinicians, and you can see this is a team from Fort Portal Regional Referral Hospital donned in their cotton gowns. And the approach we used to choose which hospital can use this was if they actually had a functional laundry service. So that because those with a functional laundry service are likely to be large hospitals, which take most patients, by deploying them, we were actually able to save quite a lot on PPE, but also reduce the amount of waste generated for every shift. Dr. Yoko talked about home-based care, and in late 2020 also this question was brought up, where we had to recommend home-based care, and because majority of the patients were either asymptomatic or mildly symptomatic. So those were some of the guiding principles, and some of the key themes included hand hygiene, environmental cleaning, mask use, and spatial separation. So, but how well can we tell if our IPC intervention was actually working? So this is a graph of healthcare worker infections between March 2020 and March 2021. And you can see the surge followed the normal epi curve in late 2020. And when we tried to investigate some of the recurring themes that were associated with these infections, they included, stock out of supplies, which led to the use of PPE where there was limited guidance, congestion in the workplace, especially when the lockdown was lifted and many people were coming to hospital, low risk perception among healthcare workers, and low index of suspicion, which was driven by burnout and lack of information. And then the use of public transport between work and home also put these healthcare workers at risk. There was also a prolonged, the issue of lab testing, where there was a prolonged turnaround time from when a test was collected to when it was returned. And this meant that healthcare workers were exposed for longer before they could have the information to make a decision. So there were also other long-term measures taken to strengthen IPC moving forward, like this facility-based mentorship model to strengthen IPC practices, especially standard precautions. And this was an intervention piloted in Kasese, Western Uganda, during the Ebola outbreak. And we're able to demonstrate that by education, we are able to increase the confidence and the IPC metrics required for a host facility-based response by just a 3 months intervention. So this model was adopted nationally, working through partners that deliver HIV care to be able to scale up IPC in other facilities to ensure continuity of routine services like immunization, HIV, and TB care. Information was disseminated through guidelines that were made in print. Some of these training materials were converted into a phone app where individuals could individually pace themselves on some of the key modules. And we're also able to develop videos of some of the key IPC competencies. And these videos are made freely available for download on the Ministry of Health website, and are always playing at the Ministry of Health waiting room or in all the waiting areas at major hospitals. So some of the next steps in realigning the IPC strategy, now we have a new tool in our bag, and that is vaccines. We plan to support increasing uptake of the vaccine among healthcare workers, because we've also had our significant share of hesitancy. Then we need to assess and close gaps in compliance with universal masking, physical distancing, and hand hygiene. Strengthening the implementation of standard precautions through the model that I shared earlier by expanding it to other healthcare facilities. And then realigning of local guidance with international recommendations to ensure rational use of PPE, since this has been quite long overdue. And then we also plan to introduce rigorous logistics and supply chain management to support the response, so that we bridge the disconnect between what's happening on ground and the technical teams at the center, who do majority of the key decisions of what is to be procured and what should be deprioritized. So the key messages we can talk, or I hope to share with you from Uganda's experience, is that COVID has posed many IPC challenges, and these will continue to require substantial changes in the way we provide care moving forward. Local context and knowledge play a key role in the process of guideline development. So it's not just enough to be right, but it's also enough to keep the confidence of the healthcare workers so that everything doesn't crumble. And it's important that IPC structures are built for posterity, rather than using IPC as a particular tool, as a particular tool in your toolbox for a given outbreak. So IPC should become the culture and not the new invention for a new disease. I'd like to thank and acknowledge the Ministry of Health Uganda, the Centers for Disease Control and Prevention, Resolve to Save Lives, and other partner organizations that we work with to bring the IPC mandate to the Ugandan healthcare system. Thank you.
Thank you very much, Dr. Ayabari. Thank you, Dr. Yukoa. We're coming up on time. I believe most of the questions have been addressed by the speakers. If there are any additional